Switzerland. He performed the IBIS-4 study, high-intensity statin therapy on atherosclerosis in patients with STEMI, a result of a prospective longitudinal intravascular follow-up study.
Good morning, Chairman, ladies and gentlemen. It's a pleasure to present the results of the Integrated Biomarkers and Imaging 4 study. In the setting of this press conference, I do not have any conflicts related to this study. The IBIS-4 trial was supported by the Swiss National Science Foundation and an unrestricted grant by Volcano, which is a IBUS catheter manufacturer, and a stent company, Biosensors. Statins, it is well known that statins potently reduce cardiovascular events, and IBUS studies have shown that high-intensity statin therapy results in atheroma regression in stable coronary artery disease patients. Acute STEMI patients have not been included in IBUS regression studies despite their higher risk for recurrent events and the high frequency of vulnerable plaques, typically extending beyond the culprit lesion, and a high inflammatory milieu which potentially triggers plaque growth. In addition, plaque phenotype is relevant in the pathogenesis of future cardiovascular events. Therefore, it is of interest to study the changes in plaque composition in response to high-intensity statin therapy. Accordingly, this study had two main hypotheses, the first being that coronary atherosclerosis regression can be achieved by the highest dose of rosuvastatin therapy, which is 40 milligrams daily, in the very proximal segments of non-infarct-related arteries of STEMI patients within 13 months. And the secondary hypothesis relating to the plaque phenotypes and to the plaque composition was that a reduction of radiofrequency IBUS-defined necrotic core can be achieved, as well as a decrease in the frequency of so-called high-risk plaques, FINCAP fibroatheromas. This slide shows the study design. The IBIS-4 trial was nested in the large randomized comfortable AMI trial, which compared a drug-eluting stent versus a bare metal stent in the setting of acute STEMI. Patients were eligible after successful primary PCI with the achievement of a TIMI greater than 2 flow, if patients were hemodynamically stable, if there was no liver disease present and no renal failure, and if in the two non-infarct-related arteries there was the absence of significant stenosis. So given these eligibility criteria, we were able at 5 centers to include 103 STEMI patients. Those patients underwent immediately after primary PCI IBUS in the proximal part of the non-infarct-related artery. Those patients subsequently received a dosage of 20 milligrams of rosuvastatin over 2 weeks, followed by 40 milligrams during the subsequent study period. The primary IBUS-related endpoint was change in percent atheroma volume, and the primary radiofrequency IBUS-related endpoint was change in percent necrotic core, as measured at 13-month follow-up. These slides show the primary endpoint findings. Percent atheroma volume amounted to 43.95 at baseline and 43.02 at follow-up, corresponding to a highly significant decrease of 0.9% at 13 months in patients receiving the highest dose of rosuvastatin. Conversely, we could not detect a significant reduction in terms of the primary radiofrequency related endpoint change in percent necrotic core. you note that there was a insignificant decrease of solely 0.05%. This slide shows the radiofrequency-based lesion phenotype analysis at baseline. You note that in a total of 146 vessels investigated, there were 165 atherosclerotic lesions, the majority of those being classified as thin cap fibroatheroma. At follow-up, 7 lesions resolved. However, there was no significant decrease in the frequency of thin cap fibroatheromas at 13 months. So in conclusion, the proximal segments of non-infarct-related artery of STEMI patient feature a high atherosclerotic plaque burden, with the majority of lesions characterized as thin cap fibroatheromas. High-intensity statin therapy throughout 13 months is associated with a significant reduction in coronary atherosclerosis. However, high-intensity statin therapy did not change the proportion of necrotic core and plaque phenotypes. The results of the EBIS-4 study are also available today online at the European Heart Journal. Thank you for the attention.
Thank you, Lorenz. Questions?
Perhaps I could start off. You have some very interesting findings of this apparent contrast in terms of the atheroma volume, but no change in the measure of necrotic core. And one of your conclusions is that the phenotype is unchanged. So I'm going to challenge you to say that there are a variety of ways of looking at the phenotype and the inflammation and other changes within plaque, as you know, including various PET and CT approaches. Do you think that other approaches may have revealed changes?
I think that's certainly one of the most relevant conclusions we can take off. So first off, I would like to stress that we did not find an increase in necrotic core. So apparently rosuvastatin is, if anything, able to halt disease progression as indicated by this radiofrequency IVUS-derived measure. Now you can speculate based on the tremendous effect of high-dose rosuvastatin therapy in terms of reduction of cardiovascular events. You would logically expect a reduction of this high-risk tissue. However, this is not the case. So my conclusion is that probably you need more high sophisticated imaging methods to be able to detect statin-mediated alteration of the vessel wall. And it is against this background that we also have decided to implement optical coherence tomography in this very study. But these results are to be shown later.
Time for 2 short questions. Yes, sir. Can you identify yourself again?
Hi, I'm Michael Reardon with theheart.org. I was just wondering if yourself or maybe some of the panelists could put these results in perspective with the culprit study that was presented a couple days ago, where it actually showed a reduction in hard endpoints versus actually just simply seeing a regression in atherosclerosis.
Sure. One of the major differences, just a short statement, the design is completely different because we have investigated those lesions who do not qualify for treatment. So one of the eligibility criteria was the absence of significant stenosis in the non-infarct-related arteries, whereas in the culprit, the lesions certainly had to appear angiographically significant to be qualified for treatment. However, still, in the absence of angiographic significant stenosis, the plaque burden in these STEMI patients is tremendously high, is much higher than in the Saturn or in the Asteroid trial, and this is just alluding to the importance of an adequate medication in these high-risk STEMI patients who appear angiographically as not having significant disease. But
more questions? Okay.